We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together. Welcome to the Healthcare Revolution podcast. Today, I am very excited to introduce my guest. We are talking about why physical therapists belong in primary care and rethinking the front door of healthcare. A lot of this has been brought to the table because of the primary care bill that passed last year in Utah. Healthcare is changing, it's revolutionizing, and we are so excited to dive in this topic. Katie is an absolute expert in this area, and I'll go into more details on her introduction. But before that, I want to just highlight the importance of this message. When most people experience pain, injury, or physical limitation, the first thing that they go to is their primary care physician. That might not be the best route, and we're going to talk about that today. But what if the system is sending patients to the wrong front door, right? That's the topic we're diving into. The majority of primary care visits involve musculoskeletal conditions. We'll talk about what that is. So back pain, joint pain, injuries, mobility limitations, but yet the providers most trained to manage these conditions are often the last person to be seen rather than the first. Our system has been developed in that way, and it's costing you time, it's costing you extra money, and a lot of suffering. And we want to collapse that time for you and solve your problems quicker. So today we're going to explore the movement within healthcare, this revolution that we're striving to create, and positioning physical therapists as primary care providers for musculoskeletal health and human movement. So today I have with me Katie O'Bright, who has really been at the forefront of all of this movement, educating PTs. She has worked as a physical therapist in the Army, in the Department of Defense, where they are respected, and their title is a primary care physical therapist, which gives such a unique perspective to what we're talking about because they have done it for years, and we'll talk about that history. But Katie O'Bright is a board-certified orthopedic physical therapist and founder of Redefined Health Education, a company focused on advancing primary care physical therapy and clinical decision-making skills. Such a cool thing that she's doing and the movement that she's creating. She earned her doctorate of physical therapy from the Temple University and completed a military musculoskeletal residency after serving as a physical therapist in the United States Army. Her career has included work multidisciplinary primary care settings, oncology teams, and collaborative healthcare environments where PTs play a larger role in patient management. Today, she teaches clinicians how physical therapists can function as true healthcare providers within the primary care ecosystem. So excited to have you on, Katie. Welcome to the podcast.
Well, thanks for having me on. Quite an introduction.
You are quite the person to have on here, so we got to have an introduction to support it. So tell us your experience working in the military. How is it different than what our system is for the majority of the public?
Yeah, so I started my career in the Army, and when I was in PT school, I knew I was going into the Army. And the reason why I knew that is because I knew it going in. I did Army ROTC when I was an undergrad, always with kind of this mindset that I wanted to be an Army physical therapist. Now, at the time when I was an undergrad, I didn't really know what that looked like. I just kind of knew that it meant working directly with soldiers, wearing the uniform, kind of supporting the overall mission, and that's what I wanted to do. So I worked my butt off, and I was really lucky enough to get one of the very few, sometimes there's none, education delay positions to go from undergrad, get an education delay, go to PT school, and then come back on active duty as an Army PT. Most Army PTs are made up from the Army Baylor DPT program, and I did not do that. So I was kind of one of the weird ones. And when I graduated, I was assigned my first duty station was Fort Sill, Oklahoma. And when I got there, I wasn't exact. I mean, I kind of knew what to expect. I had a few clinical rotations. I had one at Fort Drum. I had one. My last clinical rotation got super lucky and went to Landstuhl, Germany, at Landstuhl Regional Medical Center. Awesome experiences. So I kind of knew the Army model. I knew that I was going to be doing most of the evaluation work, determining, what do patients need, and and so with my clinical experience as a PT student, I knew kind of what my role was going to be, and I knew what the workload was going to be like. When I got to my first duty station, though, my very first boss had said, "Hey, we're doing this new thing where we have PTs in primary care in the actual primary care teams. So that's where you're going to go." And I said, "Okay,
And how many
sounds
years
good."
ago? How many years ago was this?
That was in 2014, but the Army had been doing the soldier centered medical home concept for quite a few years at that point. So I got to Fort Sill and I worked in kind of the main PT clinic for a couple of months, and then transitioned over to they call it the Fires Clinic. The Fort Sill is made up of field artillery brigades and air defense artillery brigades, and it's also a basic training installation. So
So what
it's
we
called the
see on the
Fires Clinic.
movies, is that accurate?
Yeah, it's an army post. Like that's yeah.
You got tents. You're like you're living it rough to a certain extent.
Okay, so
Barracks?
back up just a bit. There are most of the units actually have buildings.
Okay, we're not
they have
saying like
housing
tents
for
in the middle of nowhere.
No, so sometimes when you're field training, certainly there are medical tents, set up to support the field training missions. And when you're in a deployed environment, there certainly can be that. But oftentimes, when you're just working on a regular post, each unit has, they have actual buildings that people,
Well,
work
that's
in.
good. We got actual buildings for our military. Okay, so
Yes.
how are people typically injured? I'm assuming in training mostly, and that's when they come into you? All the
That's the funny
above.
part. No, I actually think the vast majority of injuries that present to primary care, or what they call sick call, which is kind of like a walk-in clinic when patients or when soldiers are unable to do their duty for the day. Oftentimes they're overuse related things. They're things it's like, man, my knees hurt so bad. I've been running a lot. It's very, very little, like probably, 10% trauma and 90% overuse, or, just mechanical issues. At Fort Sill, because it's a basic training installation, we saw a lot of stress fractures and stress reactions, bone stress injuries. So yeah, a lot of it was that. And if it was trauma, if I have to be honest with you, a lot of it was like over the weekend, my buddy asked me to, or dared me to jump off a car, and there you
Yeah,
go.
yeah.
Or, oh, I was playing basketball and I dislocated my shoulder. There's very few when you're in the training environment. There's very few like traumatic injuries that actually are the result of like, oh, we were training at a range and something catastrophic happened. It's very little of that.
I see. So what's the entry point? Like when someone comes into the clinic, is there someone triaging at the front door to decide left is primary care physician for sickness, right is primary care PT for injury?
Yeah, there's this really great picture that I think it was Colonel Goss, Don Goss. He's actually full-time faculty at High Point University now. When he was at West Point, he actually took a picture of the lines. One of them is for like, I'm sick, got a cough. You're sick, there's the sick line, and then there's the hurt line. The sick line was like, maybe 10, 20 people deep. And the hurt line was like backed around the corner. The hurt line goes to PT. The sick line goes to, medical provider.
My mind is
So
blown right now. Like
yeah.
that is the most incredible thing ever. And why is that? Why do they do that in the Department of Defense?
Because it's more efficient. So they used to do things a little differently, unless it was in a time of war, a time of stress where the system is really crunched. But for regular everyday military operations, for a long time, it actually was PT was a referral. It still is a referral. It can be. But what they were experiencing is these tremendous backlogs. Like it would take a patient months and months to get into the PT, and that is really unacceptable. So what they started doing was they started taking PT and positioning them upstream so that they could manage the really high volume. Okay. And then in that role, you're kind of deciding, is this patient appropriate for legitimate traditional rehab? Do they need to be seen at a higher frequency? Are they very highly irritable? Is this a little bit of an unstable or uncertain presentation? Those are the ones that I would kind of keep and to myself and actually want to track them for a week or two to see how the uncertainty declares itself. There's others where it's very clear. You send them to ortho, neuro, or sometimes the emergency department, but the vast majority are kind of self-management. You decide what kind of work or duty restrictions they have, and then you identify some very specific things that they need to incorporate, and then you schedule follow-up visits. So that's kind of how it
I
works.
love that. How would you define primary care PT for someone that is just, it's very foreign to them, whether it's a nurse practitioner or a PA, just can't comprehend in our system how this works? How would you define it for them?
Well, that's really simple now because in the next 30 days, you will have a published primary care physical therapy consensus definition. It's coming out in PTJ. They assure me literally any day now, but here we still are. So whoever's listening to this, it's March 20th that we're recording, so look out for it. It's coming out in the next issue.
That's awesome. And what can we learn from that? Just kind of a summary.
Yeah. So I actually will give you the definition. The definition was drafted from a series of feedback surveys. It was also drafted and kind of inspired by some of the other primary care definitions that are out there for other disciplines. Certainly behavioral health was a really big guide into that. But the actual definition itself, and I will take the time to read it, it's not that long, but each component was very strategic. Each piece of language was really well thought through, revised again based on feedback. But here we go. I'm just kind of pulling it up here so I can make sure I get everything in. Primary care physical therapy is a professional practice area in which physical therapists provide first contact and ongoing broad spectrum preventive and reactive health management services as an integral member of the primary healthcare team. Physical therapists' primary area of expertise is to address pain, disability, function, health, and wellness in order to optimize participation in life activities. The care, this is my favorite part, the care is person-centered, team-based, and community-aligned with the goal of achieving improved health with higher quality care at lower costs.
That is beautiful. Well said. Whoever, all the effort that went into that, hats off. That is wonderful, because I love, even the most important is the team-based care. And that's what we need to understand as primary care physical therapists, is this doesn't mean that you're running the show. Like, this means that you are an active participant in deciding the next steps of this patient. And sometimes that's managing it in the office. Sometimes it's managing it through orthopedic, sometimes through a neurology team, right? Like there's triage that needs to happen, right?
Right.
Tell us a little bit more about that. Like when a PT just thinks, oh, now I'm running the show. What would you say to that?
I would say to them that I think that they need to ensure that they are thinking broad spectrum, because one thing that many PTs, especially those that are thinking about primary care, think they kind of know the direction that it should be or that it is they think MSK. And one thing that we need to really truly remember and challenge ourselves in this is physical therapy is a lot of practice areas. We cover cardiovascular and pulmonary. I don't know if you remember doing ECGs in PT school, but you should.
I couldn't
we did.
Forget it. I had a lot of nightmares about it.
So that's kind of the thing, is like when we're working in these settings, we can't just be MSK. We certainly are, and that's a heavy part of our role. But we also need to be thinking about all of the pain points of primary care physicians, and some of their biggest pain points are managing heart disease and diabetes. And what can we do as physical therapists to help them manage those problems? And I'll give you an example. You have a patient with hypertension and heart disease kind of leaning into going down the heart failure sort of direction. And one of the things that can accelerate that progression of disease is sedentary behavior and functional decline. And so if there's not a physical therapist, a movement expert who's a part of that cycle, then they can spiral out of control a whole lot faster than if they had somebody who had movement expertise informing the decision making and identifying risk and identifying, frailty and risk factors like that. So certainly we're really good at MSK, but we're also really good at identifying when a patient is about to go on a functional decline downward spiral and intervene at an appropriate time.
Absolutely. I mean, you brought up some very important populations of people that physical therapists don't typically serve, diabetes being one of them, right? You think about the balance deficits they have, the weight loss deficits they have, like just their sedentarism, they're not in an active lifestyle. How can a physical therapist help in that? They don't technically have an injury, a musculoskeletal injury, but they do have other things that we are really good and positioned the most appropriately in healthcare to be able to assist with, but yet we're not engaged in the battle there.
Yeah, and I think that's probably there are many physical therapists that are engaged within that. There are many physical therapists that are offering diabetes comprehensive care programs. Is it standard or commonplace in the outpatient setting? No, but should it be? Yes. And I understand that, the way that we're paid, the way that Medicare sort of looks at what a physical therapist does, we have to kind of justify like these functional impairments and such. But I can almost guarantee you, if anybody is developing diabetes, especially if they're over the age, I shouldn't even say 60. At this point, I really should say over the age of 40, 45. And you actually go and do a 6-minute walk test and you do a 30-second sit to stand. You assess their quad strength, their grip strength. They're already going to be showing signs that are going to lead toward that frailty spiral. And again, as a part of a team, you certainly can serve that patient if you apply all of the things that we really did do in PT school. And there are PTs doing this.
Why do you feel like, or what are the biggest barriers to why physical therapists are not doing that?
That's a really good question. The first is our profession for many decades, the most recent couple of decades, in fact, focused on autonomy and focused on specialty. And there were reasons for that. And those movements and those emphases, is that a plural? I don't even know. The emphasis on moving in that direction had it served its purpose. But at this point right now, I think we have driven ourselves so far into specialty that now we are, as a profession, are functioning in silos. There's pelvic health over here. There's ortho over there. There's neuro over here, peds, geriatric, inpatient, PTs in the emergency department. Nobody is pulling everything together. And I think that the outpatient environment, the outpatient organizations, PT organizations, need to be leading the charge in this area. And unfortunately, they kind of forget that there's all of this other stuff outside of MSK that we do and that we should be doing. And when we go and we talk to physicians about our role in primary care, we're thinking about MSK, but what we actually need to be asking them is, what are your pain points? What's an everyday challenge for you and your patient population? And then work with them to be able to bring our expertise to meet their pain points. And then once you establish those collaborations, those partnerships, they really get to see what you're good at. And then you can introduce a whole lot more.
Do you see any payment problems for treating these types of cases for outpatient physical therapy clinics, for those that may be like, do we even get paid for that on the commercial insurance end?
Yes and no. No being my number one answer. So you can do everything that I'm describing in the traditional fee-for-service system. You can do it. The thing that you might not be thinking about is exactly like what to do with these patients. Can you see a patient and bill an evaluation and then see them again in 3 weeks and not just next week? Yes, you can. And for the vast majority of patients that are never going to get into our office otherwise, that's what they need. They don't need 2 times a week for 6 or 8 weeks. They don't need even once a week, a lot of them. I know this because I've lived it, and this is how I continue to practice. That's how we show high value. And that's how we show patients that we can still serve them without this model of recurrence.
All the trainings that I've done that you have put on has really taught me that we need to think, we got to use our brains. A lot of PTs get in this, they get in this rut where it's like everyone gets X, right? It's like whether it's 2 times a week for 6 weeks, whatever, they don't take the things that are happening with the patient and say, this has to be a customized plan. Every patient should be different. They just get in that rut over and over. It's like maybe 70% of musculoskeletal injuries fall that way, but what about the other 30%? They need something more specific. Is it okay to have them once a week or see them in 3 weeks? Yes, that's totally, like, some people need that more autonomy, and you just got to get them some education. Say, go work on this for 3 weeks. Let's touch base again. And I'm going to see you all year, right? Once or once a month or once every 3 months. You know what I mean?
Yeah.
And maybe with Medicare, you have to get another referral. Sure, we got to follow that system every 30 days, whatever. But that's what healthcare is about, is figuring out what is the best plan for this individual patient.
Right. And I think that there's two things, there's two kind of drivers of why that isn't happening. The number one being sort of institutional or organizational standards. Okay, hey, this is what PT is. And every eval that comes in, we want to see them stay for 12 visits, And I get it. I understand that there's a business that we need to follow. But at this point in time, payers are looking at value. And the we already talked about this, 3 to 10, somewhere in the ballpark of 3 to 10% of all patients with neuromusculoskeletal problems ever even see a physical therapist. 3 to 10%. That's where we're at. And so maybe you have the luxury of fitting in 2 times a week for 8 weeks for the 3 to 10% of patients that are actually getting to you. But if you are a PT that's going to move upstream and be in primary care, you are not going, first of all, patients don't want to do that. I know it because I've been in rotations with primary care physicians that are recommending physical therapy, and patients are like, no, that's
too
I don't want to do that.
time-consuming.
It's too frequent. It's too costly. I just don't want to get involved in that. There's a high percentage of patients that refuse physical therapy referrals because they do not want to get wrapped up into it. But then if they are introduced to a physical therapist, an MSK expert within the primary care setting that provides them with high value information about what their problem is and how they can manage it, then they have an understanding of what they need to do. And sometimes that is higher frequency care, and a lot of times it's not. So yes, you're right. You need to use your brain. And this mindset shift is the only thing that we actually need to happen in order to practice at the primary care level.
Yeah, and imagine if we all did that and we opened up our access to the other 80, 90% that never even go to PT in the first place. Because we all know around that, you said 7 to 10% even go to PT in the first place. How are we truly helping the healthcare system if we're only serving 10% of the population at the highest number, right? There's 90% that we're not even addressing, right? They're not even getting our services. And if we can change our belief system, just a slight shift, I don't think it needs to go in left field by all means, but just shift it to say, we need to use our brains enough to say when this is appropriate, and be okay with a different model and not
Absolutely.
following in the same model over and over. Is there anything you'd add to that?
I mean, I think that's a lot of it, but I have to press because I think that many right now, I think that it's in the majority of physical therapists that would not be comfortable doing that because it's different, because they don't think they're providing enough value, because they think that the patient is expecting all of this hands-on and all of this extra and a full hour visit. They think that patients are expecting that. And then when they move into this role, they think that they can't do enough. And then they feel that there's this sort of like cognitive dissonance. But I do feel like for the right PTs that really want to move forward and really want to tackle population level health, this is the right direction that we need to go. And I think it's the right direction we need to go as a profession for ultimate sustainability so we don't go extinct.
Yeah, I truly believe that. I have a difficult time teaching this in my practice to all of my therapists
Yeah.
because I teach them, a handful of these people, around 70%, are going to follow the normal plan of care with an injury, right? And then all of a sudden I go in left field. I'm like, well, this athlete, they only need to come in once a month, right? And they get confused by that. Like, well, why the athlete? Well, the athlete understands how their body is working, right? They just need a few tips. And I know them well enough because they will do it. And they did do it. They showed me in the past and they get better on their own, right? And this person just needs education. I'm going to see them in 2 weeks, right? And maybe we'll have a follow-up over the phone to make sure they're on the right track, or a follow-up over an email, right? But I think the hardest thing PTs have a hard time with is that they don't know how to read the patient enough and ask them curious questions to figure out what's the best solution for them. Because if we look at evidence-based medicine, it's truly the balance of three things: clinical expertise, like what does my brain say based on my experience? What is the patient's preference? And what does the literature say, right?
Right.
But we weighed way too much on our past clinical experience and we don't let the patient chime in. And it's not that we're letting them lead the plan of care. It's we're letting them have a say in what we're actually doing. It's like, well, I can't come in 3 times a week. Okay, well, let's talk about what's going to work best for you. How are you going to implement this? Are you going to do the homework? What more are we going to do to move the needle forward? But we're just not mending that relationship with the patient well enough to where we can get on the same page and say, this is the direction we're going to go. If this isn't working, we're going to slightly adapt that. But like, what recommendations do you have for PTs to close that gap?
I think I'm going to say something controversial, and it shouldn't be controversial, but it should add pressure. And I think that if you're having trouble doing that, you're not doctoring. Like that's fundamental differential diagnosis and clinical decision making on and individualization about what a patient in front of you needs. If you are having every patient that you see come in 2 to 3 times a week for whatever, you are not being a doctor of physical therapy who is doing an individualized evaluation and coming up with an individualized management plan. I mean, that question to me is almost insane at this point in 2026, but I understand that like our industry has just perpetuated itself by continuing with this business model that literally doesn't make any sense anymore. And so I actually, as you were talking, I pulled up this is like 2015 stuff. It's I don't know how to pronounce his last name. Alweli. It's the treatment-based classification system for low back pain. It was a revision and update more than 10 years ago at this point. This came out when I was in my like first year of active duty. But one of the things I liked about it, there's a graph here, and maybe you can link it in the show notes. I think it's public. It's not a behind a firewall or anything. But the first part of it is triage by the first contact healthcare provider.
Love
If
this.
you're seeing patients direct access, you're already doing this. And truly, you should never be treating somebody that you're seeing direct access any differently than you see somebody that's managed by a referral. There is no difference. None.
And I really want to add clarity to that, because I believe what you're saying is when we get a referral and it says low back pain, we need to make sure we see the whole person, not just the low back pain. That's what you're saying, correct?
Right. And maybe it's low back pain. Maybe the referral says low back pain, but maybe it's actually something coming from the pelvic organs. Maybe it's something in the abdomen. Maybe they have a small bowel obstruction. Like, do your due diligence, do your medical screening, do your triage, do your evaluation the exact same for every patient, regardless of how they enter the system. This is how we were trained as DPTs. So this is how you should practice. But this paper says, triage by first contact provider, determine the appropriate management approach. Do they need medical management? Do they need rehab management? Or do they need self-care management? Or maybe it's a hybrid of some of these things. I mean, that's just fundamentals 101.
Can you say those again?
So medical management, rehab management, or self-care management. And again, like I said, sometimes there's a little bit of an overlap here. Like I'll give you an example. Sometimes the patient comes in for shoulder pain, but after you do your medical, and it's real simple shoulder pain that they just need a little bit of strengthening, a little bit of activity modification for a couple of weeks, they're probably going to be gold. But what you identify in your medical screening is that they're actually struggling with a very severe bout of depression. And at that time that you identify that, because you're doing your screening like a doctor of physical therapy should, at that time, you are facilitating that connection and ensuring that that patient gets to the appropriate next step, which is psychology, behavioral health. That's it.
What I see PTs do in that scenario is they say, your shoulder pain will go away with you in a few weeks, right? And they don't really dive into the psychosocial portion. And they also kind of shove it to the side and say, that's not my job, right? It's like, go handle that somewhere else. Here's a recommendation. But why wouldn't we put in a referral? Like, here is some recommendations. I'll put in a referral for you to see that. And there's some collaboration with the patient there and getting their permission to do it, right? But ultimately, we get them to the next thing, and that's what I really try to teach our PTs to do, is like, make sure the patient doesn't stop at you. If they have a problem that you have not solved, you need to get them on to the next thing. That is your job, that is your responsibility, and that is the expectation in healthcare. We are part of that system, and we need to be driving these referrals as well to get people to the solution for their problem.
Like mic drop. That's really it. And I agree with you, though. I do see many PTs kind of say, that's not really my lane, or quote, and this is my favorite / actually like the worst thing ever, refer back to primary care. It's like, refer back to primary care for
what?
Let's
start you over.
Like for what though? Like, what is the patient supposed to do? And also, when a patient is sitting in front of you, you are a part of their care at that point. And are you considering, and this is a big thing too that we need to address when it comes to culture and mindset. Are you primary or are you specialty? Because specialists all day, like, think about it, from a physician standpoint, the urologists will brush their hands off of anything ortho, anything cardiovascular, anything that is not immediately related to the urologic system, and just wash their hands of it and go away. That is, now I hate that approach, but that's specialty care. So if you want to be a primary care PT, it's all the things. It is all the things.
And you're really accepting that, right? Unless you're seeing all pelvic floor, all neuro, like, you are taking on everything. If you are working in an outpatient physical therapy clinic that sees musculoskeletal conditions, you're really taking on primary care. That is your specific role. Would you agree with that?
And then if somebody walks in, now if somebody gets added onto your schedule with a pelvic complaint, guess what? You get to do all the screening and the triage. You might not be the person who is skilled or trained to do an internal exam or do everything that maybe a pelvic health specialist would, but you can get them started. You can triage, you can screen. Do not go to the front desk and say, "Oh, wrong schedule," because at that point, your specialty.
Yeah, you need to get them to the next step, right? Like, you screened it, you decided, oh, this is not back pain, this is pelvic floor pain. Let me get you to a pelvic floor specialist that can help take that to the next level, right? But you send them, oh, no, go back to primary care. What are they going to do? right? They're not, they have no idea that that's a pelvic floor specialty, right? So the PT is very centered to say that I know what that is. It's not something that I'm physically treating here, but that is something that we treat in physical therapy. Here is the referral. Here's the place to go. They will help you from here. And maybe there's even that coordination, even better. Like you call up the PT and you're like, hey, just so you know, I screened them. I don't believe it's back. I believe it's pelvic floor. Can you assess it and let me know? Report back, right? Like there's this reporting back that is not happening with PTs as well. And I drill that. I'm like, if I send a referral out, I want to know what happened to them because I want to make sure that patient, the problem is solved. Yeah, like we need to do a better part at that. Is like, let's close the loop, make sure we're actually taking care of these people and they don't fall back into the system. Their problems never solved. And then they hate healthcare and the healthcare never helped them, all the above, and then they don't believe in us, and then they just spiral, right? And then there's generational issues too, because it's like, well, my mom didn't have a good luck with healthcare, so I don't either, right? So let's get back to this big question that I have for you. If what we have isn't what we want, what is it? Like, what is the future of healthcare? What does it look like?
Ooh, that's an awesome question. And when we talk about the future, we're not talking about 10, 15, 20 years from now. We're talking about the next 5 years. There are really significant, like I was saying, I follow payment and policy quite a bit. And there are some really significant shifts in the way that Medicare is offering alternative payment programs. And there have been 4 areas that have really been identified: heart failure, CKM, cardiovascular kidney metabolic disorders, kind of the whole area there, MSK, and behavioral health. Those are the 4 areas that have been identified, and they are looking to, number one, manage cases better with more coordination, use more scalable digital solutions for that care. And then the third aspect is cost containment, because it's getting out of control. And so as an industry in physical therapy, if we do not, and the cool part about this is payers know that the most cost effective methods for MSK pain is for a PT to be involved in primary care. They know that. You want to know who else knows that? Physicians. Okay. And the problem is we just aren't there. We are not physically or digitally accessible at the primary care level. We are a referral. Then that becomes specialty. And so the trend needs to be that we need to be where the patients are, when they seek first contact care. Now, direct access is amazing. Love it. It's great that we can see patients without a referral. But if the patients are not self-selecting to see us first and they have no idea and they're not sure, they're going to go to primary care. That is the reality. This is why direct access across the United States has been so underutilized, and why we haven't really been successful. It's because we're still in this clinic over here, and primary care is this clinic over there. Even if you're in a hospital system where you're literally across the hallway from one another, it makes a difference. You need to position yourself and have these collaborations within primary care to ensure that patients are accessing you at the time that they need you. Because one thing that, before we move on to the next segment, like one thing that we've actually seen is that, and I'll bet it used to be Bellin, it is now Amplify Health in Wisconsin. They've had PTs embedded in primary care since like 2018. And in this system, what they were finding was before they had this program, patients would, physicians would offer PT, and then the referral to actual conversion rate was pretty poor. It was like 25%. You get a referral, only 25% of people given a referral would actually schedule an evaluation. And so there's a problem there, right? So then when they started embedding in PT, they started seeing these conversions increase, because if the PT gets an engagement, if they get a touch point, if they get an introduction to the patient in the primary care setting, the patient understands what they're getting themselves into. They know the value. They kind of know what to expect. They have initial answers to their questions, and then they actually start buying into the process. So we really need to be where the patients are from a payment perspective, from an interprofessional collaboration perspective. And again, it doesn't need to be, we need to blow up our whole practices and everybody needs to be doing this, because we will still have the people that are going to need traditional rehab. But if we do not make this move to get to position ourselves within the primary care teams, we will not be in a good place, not 10 years from now, not 15 years from now. I truly am estimating 5 years from now. And that's not just me. That's a lot of people that are much smarter and much more knowledgeable than me.
What recommendations would you give to leaders in these states to make the next move to get into those types of settings?
Yeah, I just recorded a podcast yesterday with some, again, very, very smart people, Dana Strauss and Alex Bendersky. And the very clear recommendation here is to establish partnerships with primary care clinics and ACOs specifically. Accountable care organizations take on, essentially full risk for patients and the cost of their care. It's a value-based operation. That's the way that it works. And when they have a PT as a part of their team, they will start to see reduced loss, I guess. So do you understand how this works? Like you essentially, let's just say every patient in that primary care practice gets $12,000 a year for their entire care. And then at the end of the year, if that primary care, the accountable care organization, is able to manage everything in that in-house, they get that $12,000. As soon as they start referring out for this and that, it's leakage. Okay. So do you understand what I'm saying? So like if they're referring to a clinic that is traditionally high volume, every patient that gets the eval gets the 15 visits, they are not going to want to work with you, because that's cookie cutter, nonsensical, non-individualized, non-customized care. And that's low value at that point. They want high value care, PTs that are going to be making appropriate triage decisions. You do the right the right thing for the right patient at the right time with the right provider. And it is going to be different from one patient to the next. And you have to have that capacity to do that. So partnering with ACOs and primary care clinics, whether it is digitally and you have a digital presence, like patient A comes into room number 1, and in room number 1, if you can't be there physically, they can pull up a tablet and click a button and, hey, talk to this physical therapist. Let's see what you need to do next. That is where physical therapists, leaders, and organizations need to be going.
How does the model in your mind work? You say you have this primary care physician and these PTs can't really bill for that, but they're getting referrals to their own clinic for that. Do you anticipate these primary care PTs working in that facility, but having their own entity, or being a part of that team, the primary care team, and getting paid through that primary care team?
I see it in a variety of ways. I see it where we're familiar with direct to employer models, right? So direct to employer models is we're not billing fee for service at all. We are trying to save that employer money. And that means that employer either gives you a flat fee rate to cover X amount of lives per year, or it's per member per month, or it is, we will just give you this rate per visit to make sure that that's not going against our actual insurance claims, because that's going to cost them a whole lot more money. So when you're working directly with an ACO, it's something closer to that. There's no insurance billing. It is more you're providing the care so that they don't have the leakage. And then there's some kind of feedback loop where the ACO will just kind of pay you a direct rate without filing a traditional fee-for-service claim. Does that make sense?
Yeah, that's very helpful.
So that's kind of like number one. Number two is you certainly could still do fee-for-service, and maintain your own entity, but the ACO kind of knows that the practice patterns of your organization are such that you are going to individualize instead of doing cookie cutter stuff for all the other clinics in town. The third thing that I see is actually, and this is probably on a smaller level, but like ACOs could hire PTs directly, where you're actually an employee of the ACO as opposed to having more of a collaborative relationship with a PT organization in town.
I see. That's really helpful. What do you hope the public, this is my last question for you as we wrap up the podcast. What do you hope the public understands about this model that they maybe don't right now?
Yeah. So this goes directly back to the APTA consumer report. So this was something that was published last year. If you're listening and if you haven't seen it, you really should see it. It is very enlightening. Patients of physical therapy do not know. So they kind of looked at two different populations. They looked at the general population, people that have never really been to physical therapy. And then they actually looked at people who have been patients of physical therapists. And they asked them this question, like, do you know that physical therapists are doctorate level trained at this point? And there was something like 40% of the general population might have known that. And it was like 46% of PT patients knew that. On the flip side, they asked them a second question. If you knew, or, now that you know that physical therapists have a doctorate level of education, are you more likely to seek them out for, first point of contact care, this more direct access stuff? And then we get up to 67% for the general population and like 70+% for the people that have been patients. And so I would love for the general population to actually understand what our level of education is. And guess why they don't? Because we don't refer to ourselves as doctors, by and large. I do. But by and large, the vast majority of DPTs are not introducing themselves as, hi, I'm Dr. Obrey, I'm your physical therapist. If they did, there is a difference. We have research papers that show this, that show this kind of thing. And so I would love for the general public to understand that we are doctorate level trained professionals and that physical therapy is a profession, not an intervention. And that just because you were told try PT or maybe PT might help, that really literally means nothing. That just means maybe you should have an evaluation with a physical therapist to see what you might need. That's really what it needs to turn into, because what it has been historically is you're referred to PT and then the patient kind of expects that they're going to go through this whole process. And there's a huge percentage of patients that don't want to do that. In fact, I'm one of them. Because I don't see the value in going to a cookie cutter physical therapist for my problems that are unique to me. And I don't have high confidence that they would be able to customize a program for me, and unless they're, kind of the outliers that are leaving clinical practice and kind of going to do their own thing anyway. So I'm being super hard on PT right now. I am, but I hope that it will not just piss a lot of people off. I hope that it will actually make us look in the stinking mirror and be able to see what we've done and what our pathway is if we keep going down this direction, but what our pathway could be if we adapt and if we modify and if we actually move forward with this concept of what primary care is.
So I love what you're saying. I love that you're saying that PT is a profession, not an intervention, right? And the thing is, what you're saying is innately us. And that's the adaptability, the customization. That's what we do every day, right? But for some reasons, we're having resistance in that area. So I appreciate your insight so much. And thank you for the work you're doing all across the nation. You are making a significant impact. You're like a one-woman show, and you're just like going around the nation, just setting fires up everywhere in such a powerful way that's really getting us to think deeply and challenging our belief systems and challenging us to think differently and thinking about how we can truly serve that other 90% that never even touch therapy. So thank you for being on the podcast. Thank you for everything that you do. Really appreciate you.
Thanks so much for having me.